Rhode Island to a different set of standards than normal insurance. So your colleagues in Rhode Island actually gave health insurance regulation a different set of standards, somewhat like what you've done with the Green Mountain Care Board. Before that, I ran a health plan started by community health centers in Rhode Island focused on the Medicaid population, so in Medicaid managed care. Not a clinician, have worked with staff model HMOs, big fan of primary care. The rest of it can wait for the presentation. Thank you.
Well, first, let me thank the committee and your chairs for inviting me to come. I really have the opportunity to try to help us all rethink clearly healthcare, especially at this moment of crisis in Vermont, which being interrupted. If you have a clarification question, besides the fact that I'm not speaking loudly enough. So I welcome interruption and feedback if it's for clarification. I think big questions about what does this mean for the future of healthcare, those I would encourage, I assume will come back. That works for you.
And Ellie and I have shared our slides beforehand. I would suggest that the broad conversation happen after both of us present. Yeah. The questions are great with the presentation, but they fit together, and so we might.
So let's make this a decision. If you have a question of clarification, you don't understand something, or there's an acronym, or there's something else you'd like to know about, ask a question of clarification during the presentation, and then we'll hold off until we've heard the whole thing. So it will fit together. So we've been told.
Yeah.
Thank you.
We hope.
Yes, we hope.
All right, here is the gist of the argument that I'll be making. I don't need to emphasize the first one. We have a crisis of affordability and access in Vermont. I think it's fair to say that the largest driver is the Vermont hospital inefficiency and our weaknesses in primary care. I think from looking at the data that there's at least $150 million on the table that could be saved within a year. And the savings in the longer term, I'll share my research and others, I think it's 25 to 50% of all healthcare spending. And I'm known to be an optimist, so take that with a grain of salt. To make progress, however, and I'll spend some time on this, we need to address the deeper causes, and I'll explain these later. I think the goal is competition where possible, regulation where necessary, and getting the incentives right so that people self-regulate toward improving health, improving care, and lowering costs. And I think my argument will sit in the middle there, that to be able to do that, we need strong, effective, and aligned state agencies and healthcare organizations who actually deliver the care to achieve, because the real aim is off further to the right, better health, better care, lower costs. And I think Vermont is well positioned to be a national model, although right now I think we're not a national model that's not, we can't be terribly proud of, since we all know this graph. One of the things I think is so important is trust. And some of you may have seen an earlier version of this graph that I did with silver benchmark plans, where the right-hand side, Vermont, looked like a rocket going into space. This is a much more accurate reflection of what's actually happened to average costs, because that accelerated graph of costs for the benchmark silver premiums was based on some things we did to draw down more money from the federal government. But this graph applies to everything we know about other sources of judging the cost in Vermont. Notable things, Maine, New Hampshire, and the rest of the United States are all doing much, much better than we are. And we are an old state, but we're not as old as Maine or New Hampshire. And these are just some public comments from 167, which you are all familiar with. We all are concerned about hospital sustainability after the report from 167 and national data that points to the challenges facing rural hospitals in the United States. We have 4 that are at high risk of closure in this state. And, the financial threats to all of the hospitals are real as their margins decline, their bond ratings are threatened. And so in the Hammery report, if you look out further, nobody looks very good on the current trajectory. None of our hospitals look very good in terms of financial performance. Okay, loud enough.
Yes, thank you.
Doing great.
And primary care is in crisis. Based on some recent analyses, 100 million Americans lack adequate access to local primary care, and we hear that from residents of Vermont. There was a very interesting United Healthcare report from a couple of years ago. It's not peer-reviewed, but they looked at nationally representative claims data, found 27 million emergency room visits among commercially insured. Actually, I don't know. It could be all payer. It could include Medicare, but 27 million. No, those are commercial patients. The average cost of those visits was $2,000. They thought 2/3 of those could have been cared for in either an urgent care center or in primary care at a national potential savings of $32 billion. It would gradually run up. We could achieve those savings. In Vermont, if you assume the 84,000 visits that I've heard quoted, correction maybe from David, that it could be 67,000. But if you assume the potential savings, and for example, we set up an urgent care center next to the emergency room, we might be able to take out $100 million in saving by improving primary care access in Vermont. How to do that? Thank God Chris is here. He's going to tell you how to do that. Oops, I didn't delete. I've got most of these in bills, but I didn't delete the one that I had there originally. So anyway, we think we know hospitals make up more than half of the spending in Vermont. And we've seen increasing commercial prices compared to peers. This is UVM over the period between 2015-17 and 2020-22. While other academic medical centers, in New England, are delivering care substantially less expensively to our residents who are people who are under commercial plans. And they've been going down. We have been increasing. So why that is a topic of discussion, but we've had increasing commercial costs. When you look at other sources of data, and it's not just for UVM Medical Center, although I know that's been the focus of public attention, but analyses suggest that all of our major hospitals, not excluding the critical access hospitals, have substantial opportunities to improve their cost performance. If you look back 10 years, there's this complicated measure of the ratio of costs covered by Medicare payments, which lets you say, if you're at 100%, that's good because your costs are the same as your price, as what you're charging. You can break even on Medicare. We've fallen behind nationally, for both UVM and the non-critical access hospitals. So we're now losing 27 cents on every dollar, but that's because of our high costs compared to what we could be doing if we were mirroring other high-performing health systems. So there's a cost efficiency challenge that our hospitals have that we should be figuring out how to help them with. This is just data for UVM Medical Center, but it raises concerns that we may not be being as efficient as we can when we're working as clinicians in terms of how we're spending our time. We know that 36%, or from the data I've seen, 36% of specialties are in the bottom quartile of productivity, how much work they do when they're on the clinical time. But 80% of the specialties at UVM Medical Center are in the bottom half. Question?
May I?
Yeah,
Clarifying
please.
question. When you're speaking about productivity, are we talking about like amount of time they're seeing patients?
Yes.
Or, okay,
I understand it's supposed to be measured that way. FTE, clinical FTE
okay.
against how many RVU, how much revenue you generate, which is an awful way to judge physicians. I'd rather have them measured on health outcomes. But it is how they're spending their time with their patients and how active they are as clinicians within their specialty. Surgeons, most of their RVUs are doing surgery, and we know their waiting times. Yeah. So yes.
On a similar note, the advanced practice nurses often don't get reimbursed the same as physicians. So when you're counting productivity and using revenue, have you taken that into account?
You know, that's a great question. I am, you may know the answer. Chris may know the answer.
I think, and clinician or health systems folks can correct me, when this productivity, the units is not dollars. Where advanced practitioners get paid less is what they call the conversion factor, the dollars per unit. And Medicare pays advanced practitioners less per unit. So when we say that advanced practitioners are reimbursed less, it's because that technical term conversion rate, but the unit is less. I believe this comparison is for the relative value.
Yes,
units.
exactly.
Okay.
Which would be the same if delivered, if it's for that CPT code, if delivered by a nurse
Okay.
or by a clinician.
And great sympathy for legislators who have to learn about relative value units to do.
We'll leave that to the regulators. No. Representative Chena has a question. He's on Zoom. So Representative Chena, go ahead.
Thank you. Is paperwork considered productivity and administrative duty?
No.
It probably, if it's on your clinical time, that's going to be counted against you because you don't get any points for that, and it's wasting clinical time.
Oh, hold on a second. So you're saying like when we say in this in these numbers here that time spent on paperwork is not being considered productivity?
No, it doesn't, because you can't bill for paperwork. You don't get credit for paperwork as part of your productivity. So paperwork distracts you and keeps you away from doing the work of patient care itself, which would generate a claim for seeing the time you spent with the patient.
Thank you for clarifying that, because honestly, as a healthcare worker, when I saw this, my heart dropped and I was like, how are we wasting our time? But if you're counting paperwork as not productivity, it makes a lot of sense.
Yeah, how can you be productive when you're consumed in a system that's about documentation? Great question.
I was just wondering, are these numbers compared in the quartile to equivalent academic medical centers, or, I mean, I'm assuming.
I think so.
Academic setting.
Chris Whaley, I'm trying to remember the spreadsheet I looked at. I think it is almost all academic medical centers.
Okay, thank you.
But I may be wrong on that. And this is older data. Chris Whaley could be asked to give an update on the data and whether it's improved. I'll plug along.
This is if I
One
can,
more question?
yeah, this is a basic clarification. Not everyone knows that Mary Hitchcock is Dartmouth.
Oh, yeah, that's a good point.
Yeah, so just
That-
so the room knows.
That's the way it's labeled. And those numbers are actually percentages. So 317 equals 317% of Medicare, which means 3.17 times what Medicare's price would be. That's a really, thank you for asking those questions. That's a really important clarifying question.
And since we're going, it's worth noting that whether it's 165 at Tufts or 317 at UVM, the same service is being reimbursed at 1.5 to 3 times more when it is provided to a patient who is commercially insured. So employers, not just insurers, employers are paying 3 times what the federal government is paying for the same service.
We'll come to actually I think the next bullet You know, the Vermont Healthcare 911 analysis that came out on a white paper last year was that if UVM adopted the cost efficiency of its peer academic medical centers, the savings would be $170 million. And this is just for administrative costs. This is not clinical administrative costs. This is what they refer to as the higher level network and administrative. There's a bucket that is just administrative costs, not even administering a clinical program. Like cardiology administrative costs would not be included in the general administrative costs. And as I'll show in the next slide, I think if we started to bring everyone together toward a goal of improving health and lowering costs, we could do much better. We could reduce, I'll show you that data in a second, right now, in fact. So, you know, the reason I ended up being on the road starting 25 years ago was we showed that about, you know, if we could get everyone to practice like the pale green areas there, we would save 20% of Medicare spending. And it's mostly for discretionary utilization. It's how much time people spend in the hospital where they would not be spending time in the lower spending regions, in the pale green regions, and how many specialists they see and how much time they're spending visiting physicians. And there were no differences in outcomes or quality across the different regions of different spending. When the academic medical centers got angry at us, we repeated that analysis, comparing the best medical centers in the country, the top 100 that they thought we should look at. We found exactly the same thing. So across academic medical centers, the lowest cost centers, which included, you know, in terms of measured as utilization, so not ignoring prices, we standardized everything. The lowest cost academic medical centers were doing it for 30–40% less than the higher cost centers. And the outcomes were equal across these academic. So there's real opportunity to improve performance. It's also that analysis ignored pricing differences, and we're all familiar with the important role pricing differences in pricing make, because some hospitals can charge higher prices than others. So it's about 50-50. Prices explain half of the difference from utilization, unnecessary utilization explains about half of the difference. So if we want to make healthcare better, we have to pay attention to both. And then this is, I think, a very important article. I'll walk you through some of the work from Intermountain Healthcare. This is an article by Brent James, his colleague. Paulson's first name is missing. But they argue that we could achieve dramatic savings. You know, the estimate from this article is that they could reduce at Intermountain Healthcare, they expected to be able to reduce costs by 50% if they were under a full capitation model where they could take advantage of the savings from all payers to invest in the work to keep people healthy, improve the quality of care, and do the administrative work to take costs out at every opportunity. So just a couple of case studies from them. So this is what they did over about a 2.5-year period. It's not even quite 2 years. They were trying to figure out how to improve the efficiency of hip replacement, the most common surgical procedure that's done in major surgical procedure that's done, especially in the Medicare population. It's a great procedure. Are any orthopedic surgeons wearing white coats over there? I can't remember which one of my hips.
I should have introduced them earlier, but they are residents from the University of Vermont Medical School in OBGYN. And
Back to you in
happy to have them here.
Back to you in a second. So it's an amazing procedure. And if you want to pay attention to reducing the cost of doing it, it is possible. How many people are unfamiliar with that little spinning wheel at the bottom? That is a plan, do, check, act cycle that people in quality improvement do religiously to figure out what is the thing we should test next in order to reduce the cost. So the first rotation of that would say, let's try this. Let's try, I'll make something up. Let's try to see if we can reduce the administrative costs associated with admitting the patient and discharging the patient. So that could be the first cycle. That could be pretty easy to do. It's less paperwork, automatic, whatever it is. First cycle, spin, you plan to do it, you do it, you test what you evaluate what you learned, and then you go back and say, did that work? Do we want to scale it? What's the next thing we want to test? And that would be another improvement cycle. This was all taught to us by Don Berwick when he brought modern improvement science from industry into healthcare about 30 years ago. This is the one system back in the 80s and 90s that was doing an outstanding job of introducing this across the whole system of care. That's what Brent James was doing. Here's another example. Cardiac procedures that are needed to be done in a cardiac cath lab, probably one of the most expensive inpatient services we have, also one of the most profitable. This shows the rate of cardiac catheterization over a several year period. Where they started to lower the rate, it was when a guy named Don LePay, who was head of cardiology, said, let's get rid of inappropriate cardiac caths, inappropriate procedures. There was a lot of excitement about the high rate of inappropriate cardiac catheterization and related procedures in those years. And they said, let's do something about it. They reduced, with a simple checklist that Don LePay introduced in order to get your patient into the cath lab, supported the point of care, made it easy for the docs, took care of prior authorization. So doing the checklist, he got the plans all to agree that this was prior authorization. They didn't need to spend hours on the phone. And they reduced the rate of inappropriate procedures by 24%. They lost money, of course, as a hospital. Luckily, yes, please, sorry.
Cardiac nurse here.
Yeah.
Was there an analysis of, were there cases that were missed because it was determined that going to the cath lab would be inappropriate?
So
thinking about women who typically present with HHC
yes,
symptoms.
the only thing they had in the input file was what the doctors wanted to get done so the application was the physicians, and if the physicians wanted to override the checklist, they were free to. They could just say, this is important, I'm doing it. I do not think they were looking at that time for all the people not yet seen, evaluated sufficiently to manage their heart disease. And I'm sure there were missed opportunities to improve medications, improve blood pressure control, improve treatment, and maybe some people who should also have gotten cardiac cath. Great question.
1989. It was a while ago.
Sorry?
1989.
It was a while ago.
Yeah.
I'm sure we weren't paying any attention to women then. They weren't even in NIH trials. From a family of 4 other women, so.
We've been sensitized.
Sorry?
We've been sensitized.
Not adequately, they would tell me. So, this is, I think, a really important story. It's a long time ago. There's a sort of a parable of American healthcare, and I'll mention briefly some other places that are more modern. Charles Sorensen established a goal of keeping care affordable for the whole system, aiming to hit the consumer price index plus 1%. Really remarkable goal. It's not what we've seen in Vermont in the last 10 years. And his strategy was to improve care and eliminate waste. They did have their own health plan, Select Health, for which, if they improved care, the plan saved all of the money between what was expected, what the revenue that was paid, and what they were spending. So they had a powerful incentive, but that was sufficient to cover the full costs of the initiative. So what you see is what they achieved, which is about a different version of this slide, $700 million on a $5 billion. It's someone, where are those residents who got calculators in their pockets? Anyway, there were big savings achieved over the period where this happened. And they had the highest bond ratings of any nonprofit in the country at the end of that period. Because what you want as a hospital is solid finances, good margins, that gets you a good bond rating and that lowers your costs of borrowing. And it's possible. So I just gave you examples of what happens at a practice level if we get clinical practices, whether primary care practices or cardiology practices or orthopedic practices, to improve care. You can both save and improve outcomes. The outcomes in the cardiac cath lab were better. When you do it at a hospital or health system level, you can do it. But I've now tried for 35 years to slow the growth of healthcare spending in the United States, and I've obviously failed. We have not slowed it one whit. And so I've recently stepped back to try to understand what have we been missing. And I think there are two pieces of that. The first is market failure. Healthcare is rife with market failure. Whether it's about how patients make decisions because they're told to get things by their clinicians, that's an issue of how markets work at the most basic level. But it's also challenged by monopolies. And right now in US healthcare, 90% of markets are too concentrated for robust competition at the hospital level, which means they can do what we've seen happen in Vermont, rapid escalation of prices. Allowing hospitals not to be in competitive markets leads to other things as well. They can be inefficient. They can ignore quality. The data on the quality of care in markets that are not competitive is not encouraging. Quality is actually worse in uncompetitive markets because they don't have to compete on quality. And, they can allocate resources without regard to their public missions. So there's a second problem, which I want to blow up a slide to have you look at, which, I label the balloon problem. These are just some of the ways that in a healthcare system, when we try to squeeze in one place on the balloon, those who are on the other side can push out in some other place. Whether it's public payers controlling prices, we think you should live within your costs. Oh, we can raise our prices to others. Bundled payments, they're a very important way of perhaps improving care, but it's very easy to shift costs out of the bundle. And so build commercial payers and Medicare twice for the bundle. So you shift the expensive tests outside the bundle that you were previously going to be paid for and get paid twice for them. ACOs, which some of you may know, I spent 4 years in Washington trying to figure out how to get them to be launched. And everyone in Vermont now hates it. Raise your hand if you hate ACOs.
Not every HCO, just one
Our
ACO.
public advocate raising his hand. But the challenge with ACOs is you can use them to keep some of your patients out of the hospital and then fill those beds with higher paying commercial patients. And so there is evidence that for the patients in the ACO, if the ACO is run by primary care physicians or physicians and not owned by hospitals, they can reduce costs and improve care. But the evidence on hospital-owned ACOs, maybe we see that in Vermont, I'm not sure. I don't think the people in the, so, and if you limit plan profitability, well, you just raise premiums or offer shift to low value plans, et cetera. The worst one is our effort to increase high deductible health plans, which just shifts costs to consumers and leads them to make poor decisions before they've hit their deductible. The data is pretty good on this. You skip the stuff you need if you're going to have to pay the full cost. And then once you get the deductible, who cares? You're going to get everything whether you need it or not. So I think states, and this is a paper that Chris was kind enough to agree to help with, we tried to look back at what explains our failure and where might we look in, ways to make things better. And we landed on this notion that it is about effective state agencies charged and resourced to improve health and care. States have actually more authority. The feds can't intervene and do this all down here. We are the ones who can do this. And you'll notice that off on the left-hand side there, I've had this idea, which is increasingly talked about. And this is, remember, I'm now talking at the policy level, a learning healthcare system where our aim is affordable, accessible, high quality care and better health. And then we use that improvement model to measure what we need to measure, evaluate, plan, and then implement what the things that we think are going to make a big difference and make sure we see how we did so we can change course, adjust it, and move on. And that's I think what my pitch would be is basically at the theory level. Luckily, Chris gets to tell you how to actually do it. We need better data and we need transparent evaluation. We need to know, I think everyone's curious about what is the cost data from our hospital. We're all in the public confused about who's right or wrong, the Green Mountain Care Board or UVM. Let's just get a level playing field and have some audited financial data that's using the same system of accounts. And we can all understand where the efficiencies are and the inefficiencies are within our hospital system. And then use that to evaluate what's going on and make suggestions about what to improve. We need real-time quality measures. That's a different topic than today. But we need it at both the practice level, as I think I suggested in those initial slides, the hospital and the practice. But we also need it at the larger level of health systems and regions where you guys are responsible for helping us get better. Use the data to identify drivers of poor performance. The article is actually pretty readable, and I know that we can make it available if any. It's only 1,200 words. That's why it doesn't make any sense, because it's too simple. But Chris let us publish a working paper on his site that goes into many more of the details about the argument. So I'm also happy to take follow-up calls from anybody. And then, there's a term in medicine called turfing. So any calls I'm welcome to take, but I'll turf them to my colleagues. When a resident is trying to give someone else a job to the intern, they turf it to the intern or to their chair. So the second idea, strengthen planning and implementation. That's for everybody. I think we need a state strategic plan for health and healthcare. I think we want to align hospital strategic plans towards system transformation. I think it's almost, and I hadn't really thought about this until getting ready for this work this last month, that we let hospitals develop their own strategic plan. Well, how on earth is that a good idea? Shouldn't it be aligned with what we're trying to, they're nonprofit institutions. Shouldn't we get to give them feedback on their plan, not just the people who are on their boards, but their communities and the state as a whole, or an evaluation and planning unit? Question, yes.
Do you
Thank you.
have any states in mind that do have been able to, that are stronger, that have a state?
This is his. I'm gonna leave all the questions hanging. Chris is gonna.
That's the question that waits till after they both presented, but it's a good question.
It's a great question.
If I could ask, did you say this article will be available to us? That you would give us a link to this article?
Oh, certainly.
That would be wonderful.
If I have given it to Kiki, but I can certainly have that and the link to the link to the Millbank site.
Great.
Kiki, can you help me remember to get those to the members of the committee? And then the third thing is, need all payer oversight, payment reform, and regulation. It's nuts. I'm sorry, that's a technical term. It is nuts to ask a practicing clinician or an office-based practice to deal with 20 different health plans, to deal with 20 different sets of incentives. The reasons ACOs failed or aren't living up to their potential is that you're under an ACO for one, but you're still under fee-for-service. 70% of physician revenues in the United States are still fee-for-service. Yeah.
I'm going to ask a question there. So the hospital health plan is one thing, its strategic plan is one thing, but then commercial insurers are also doing the same thing. So how do we?
Great,
How do we?
great addition. We should
Yeah.
have them.
Okay.
There's another bullet that needs to go on here that
Okay.
says,
Okay,
engage our health plans
there you go.
in strategic planning around what we need. And of course, it should have primary care or community-based health plans, health systems that are, all of us should be part of the same goal, have the same aim, and then figure out how we're going to do the work together to get it done. I'm sure Mr. Foster will be happy to take all those responsibilities on. We'll talk about that when he's here. Question? Are you okay?
Yeah.
Okay. So I think there are the reasons to do this is the market failure and the balloon problem. And unless you get your hands around both of those to create competitive markets where possible, and I think we can have academic medical centers competing with other academic medical centers in some other place to show how they're doing on the metrics that we want them to perform well for. I firmly believe in competition choice. And then we need someone to set the table that makes that possible. The last thing, of course, you need to do is measure impact. So just a few few concluding thoughts. We all are hopeful, many of us are, that the AHEAD model will be successful, bring great resources and capabilities to the state, but I don't think we can have confidence in that happening. So with or without AHEAD, and we can't afford to wait 3 years to start controlling healthcare costs. So with or without AHEAD, we need to do something. And I wrote this sentence before I heard that this governor's budget includes some bridge funding for primary care and SASH. I'm not sure it's sufficient. We may need additional investments. I already suggested that if we invested now something in primary care, we might get real savings from the hospital in the pretty near term. So I think the questions are, can we start now to advance better pricing and volume controls on the hospitals? Advancing the notion of a global budget in quotes, that is, what should they be spending and how we get them to live within that budget. Build now on existing strengths that we have in the state in quality improvement and primary care, and then prioritize high impact initiatives. The most expensive service delivered in Intermountain Healthcare was pregnancy and newborn care. That service line, that was the first thing they prioritized in terms of investment in order to keep kids in utero, in the womb for as long as possible. So and then take great care of the moms and the kids so they get a great start. It was a profoundly impactful, and we still have our OB residents here. So it's where to start in the improvement. I don't see why any delay in starting the improvement work has to occur, has to wait for you guys to pass a bill. Maybe it's the bully pulpit, so I'm really excited that you're so interested in this. And I know I've spoken too long. Over to Chris.
No, you haven't. This has really been extremely helpful.
Yeah.
Can you, on the bullet administrative and other costs, can you again go into detail about what you're looking at, what you're calling administrative?
Let me look at my slide here. Oh, back slide.
No, it's before that one.
Oh, administrative and other costs. I think it looked as though the lowest hanging fruit is the category of spending that falls under administration and general services, I think is the name. But you should, Tom Reese is knowledgeable and was the one who did most of those calculations. Similar data comes from different consultants that the board used last summer. But that is, and actually this is not a bad moment to tell one more story because you've reminded me. So, there are other hospitals in the country trying to live under their Medicare costs, within their, break even on Medicare. One of those, I understand that Tom Walsh, who's a board member, has reached out to Peter Pronovost, who's leading their care transformation, and he has agreed to come talk in Vermont. What the public data about Pronovost's work and University of Cleveland Medical Center's work was that in 1 year, they took out $250 million in administrative costs in 1 year.
I have a bill that gets at reducing executive compensation.
You introduced it?
Yes.
Great.
Is that,
Topic of
is that
conversation.
in that bullet?
I think that, great question to ask Peter. Peter Pronovost, when he comes, I think the tension we face right now in American healthcare is that this is a really hard job, especially now if you add to one, rather than just increase your revenues, you're going to have Elliott tell them they should be improving quality as well. It's a very competitive market to recruit the kind of capable leaders that can do that work. And I bet Chris will have something to say. So I don't know what the right number is. I thought it was I didn't think that the compensation we saw is representative of the kind this year is representative of the kind of that I saw in the leaders I've spoken to at Intermountain Healthcare who took reasonable compensation, but nothing like the compensation that was received here. So it's a good topic of conversation. I don't know what the right answer is.
Peter Pronovost.
Pronovost. You can ask him about the hard question. You can ask him what he's paid.
So I think you indicated that he was being invited by Tom Walsh into the Green Mountain Care Board. And so one of the fine lines that we walk in this building is becoming the regulatory entity versus giving the umbrella policy to the regulatory entity. So those are the conversations that we're going to have when he's invited and goes into the board. That'll be an opportunity for us to hear and understand where the line exists for us. And I think that's important for all of us to understand. I think we see the media reports, we read all the details, we understand that there are things that need to happen. Yet some of those things that need to happen should happen at the board. And what we can do is to give the board the authority and the enthusiasm and the platform to move forward. So I want us to be very careful in here that we don't step into that regulatory thought process. Although all of the information that you presented, or a lot of it, takes us in that direction, but it helps us to understand what we can do, what our role might be in this, and that's
Direction setting.
going over.
And if I may, I'll talk a little bit about this. Senator Lyons, I think that's an excellent point. I think the other thing you can offer is accountability.
Yes, you're absolutely right.
Bring to this table to be accountable to you. I think as someone who's been in the executive branch and has been lectured by legislators to say, you're doing policy making, that's my job. It's not an easy line, but the way to figure out that is accountability. It's to make sure that that you are holding the entities that you've given statutory authority to accountable for some objective outcomes around how are we doing on these things we told you to do.
Thank you. You're absolutely right. Combination is dynamite.
And part of the reason for my presentation was to lay out dimensions of things that I want you to think about holding others accountable for. Because I think accountable for improvement. We want to see continuous improvement. We want to see an annual progress toward lower costs and better care. Great. I'm done. Over to you.
Okay, the first test is the technology.
There's the rub. Yeah.
Yes,
What-
David Merman,
Yeah, David Murphy could be Mount Careful and speak a little bit, but Peter Pronovost is going to be, I think, towards March 5th, I believe.
Oh, great.
excellent. March 5th.
Yeah.
Well, and it's before crossover. Yes, that's a good thing. It's also during the week that we're off. That's a bad thing. But we'll be able to zoom into that, I would think, or
Yes.
at least look at the recording of it.
Yes, and if you zoom in, there'll be plenty of opportunity for questions in the public comment period at the end. You guys aren't usually the public, but in the context of a board meeting, it's a great opportunity.
Thank you. Is there, can you ensure that we get that information sort of?
Yes.
Thank you. You can send it to Kiki and Lori. Who's your, Kristen, sorry. Kristen's new, but if we send it, we'll get it. Thank you. One question.
I'm interested in accountability because people come and they give all their data and then they sit there and then what? So I don't know, once we think about accountability, what's the next steps? And maybe you're going to talk about that, but I feel, yeah. So thank you.
Did you want to comment on that or?
No, I was looking to you.
Right, we're gonna-
Hold that till afterwards or?
Yes, great question. I think it's kind of teed up. It's a really important one that we can talk about as a follow-up to this. So may I proceed? Okay. Thank you very much for the chance to speak with you all. I think, well, here's what I'd like to talk about today, just to make sure you understand, Millbank, revisit the notion of a problem, particularly you folks as policymakers, talk about some barriers to state health reform. I was asked specifically to speak about policies to address rising commercial prices, and then step back a little bit and think from Vermont. It's important if you're sort of thinking about roles and responsibilities. I don't bring anywhere near the technical expertise that Dr. Fisher brings. I'm not a clinician. I have the scars of working on this, particularly from the executive branch side. And then we at Millbank have the real privilege of working with state policymakers such as yourself. So we try to have a sense of what's going on in other states. So that's the sort of the perspective that I bring to this. The Millbank Memorial Fund this is our mission statement. We work to improve population health and health equity by collaborating with leaders and decision makers and connecting them with evidence and experience and sound evidence. We really focus at the state level as opposed to federal level because we think states are where the action is. As Dr. Fisher was saying, frankly, it is where we have experience. And we like working with you guys. You know, this is we have a lot of respect, appreciation, support for public service. You guys could all find easier ways to spend your time. And we appreciate the commitment that you make to doing this. And our role is to help you do a better job with it. We have 3 particular program areas. That's what these bullets are. We do a lot of state health policy leadership development. We work with folks in both the executive branch and the legislative branch here in Vermont. We work on particular issues, notably primary care and sustainable healthcare cost affordability. I think that's what brings us to the table here. And then we publish Millbank Quarterly, a peer-reviewed journal, as well as papers to support our work. In a side gig, I have taught U.S. health policy. And when I sit with public health students, I say the important thing is, really important thing when you're thinking about policy is say, what's the problem that we're addressing? And it's really hard with healthcare because it is 1/5 of the economy. And so you ask 20 people what the problem is in healthcare, you're going to get 20 different answers. Is it a notion of, sorry, I can't figure out how to turn off my alerts. Is it a notion of affordability? And if it is affordability, whose affordability? Because a Medicaid agency, a state budgeter is going to find affordability very differently from an employee who's looking at a high deductible. Is it access to services? Is it provider sustainability? We have a particular issue. We talked about rural hospitals, health status, quality of care, differential health status. And I think it's really important as policymakers that we know what the problem is that we're taking on. Dr. Fisher has made a strong case, and I would support it, that in Vermont, we have a particular problem with the rising costs of commercial insurance driven by rising provider prices, especially hospitals. That's not to take away from all the other issues that are important when we're trying to do this Rubik's Cube around patient access, around sustainability of providers. But it's our belief, and I think that's the case in Vermont, that affordability is it's important. It's frankly politically important because it's what people feel, and it's a way into some of these other issues. I would note you're not alone in this problem. When we work with a number of states around looking at what is happening to healthcare costs in general, we consistently find that Medicaid and Medicare are relatively under control. The problem is commercial. And when you look at commercial, the problem is prices. It's not utilization. This is increases over time. I'm not talking absolute cost. And the increases are in commercial hospital prices and pharmacy prices. So if it's any sympathy, you're not alone in your pain. More generally, and this is what Dr. Fisher is getting at, is that in the US, we have an unbalanced healthcare delivery system. If you look at high-performing health systems like Intermountain in the US, and if you look at other countries, you'll find that they spend a lot more on public health, a lot more on prevention, a lot more on community-based services, and a lot less on specialty care and hospital care. And that has consequences. It has consequences for public health, has consequences for the money that's available for education, social services. There's looking at consolidation proposals, and a lot of those are driven by the district costs around healthcare. Saw the article in the Digger, and that money could better be put in people's wallets for what they spend. So there's no other no other country where healthcare consumes as much resources as they do in the US. And that's a real problem for you as policymakers, because as an economist says, the iron law of healthcare is that my expense is your revenue. These are jobs. And we talk about meds and eds economy. And so it sounds great to say we're going to take money out of healthcare, but that's somebody's job. And that's a real, it's hard. Welcome to your job as policymakers.
This may be for later, but do other countries rely on competition the way you are suggesting we should? And that may be a later question.
At a high level, no. There's much more of a. We were talking about this. We shared a car ride up from White River Junction. What would happen if you had publicly funded medical education for everybody? It would completely change the contract around what clinicians we train and where we put them. And that's publicly funded medical education is intrinsic to most of these other countries. Now, we can't wave a wand in Vermont and change that, but we know what we're navigating towards.
But maybe we come back to other country models and competition versus single payer and what that means.
Thank you.
If you're curious about it.
So you saw data from Dr. Fisher. This is just another piece, actually from the same source, around Vermont's prices as a percentage of Medicare. What I've done is in very high-tech form, I've highlighted the 6 New England states and pointed an arrow towards Vermont. This is exactly the same data source that Dr. Fisher had. It's just a different way to present it. This data is actually available at the hospital level if you want to look at it. I'm sure the folks at Green Mountain Care Board have done it, but it's just to supplement what Dr. Fisher was talking about. And again, these are, just to emphasize, these are multiples of Medicare. So we are asking employers and us employees to pay in Vermont 3 times what Medicare is paying. And the dynamic, I've seen this this is the balloon problem that Dr. Fisher was talking about. And I've seen, I'm not going to name particular health systems, but it's economically rational behavior. I get what I get from Medicaid and Medicare, and then I get what I can from the commercials. And that is economically rational behavior for a health system. And that was what I learned as a regulator. If you don't like the way people are playing the game, you got to change the rules. You can't, my job there was a referee, and people are just playing the game. And you can't expect them not to do that. I was the referee. I had to change when I blew the whistle. Okay, so big big picture, two barriers that states face when you're doing this work of taking this on. Dr. Butcher already said it, aligning policies between payers. Clinicians rightfully say, stop the madness. Why do I get paid 3 times the amount depending on what insurance card they're having? Why do I have to deal with different quality measures, different paperwork requirements? We had that request earlier on. Providers really want alignment, and we need alignment for system change. A bigger one, and we're going to get into this, I think, in terms of the accountability question, is how do we do the work that Dr. Fisher talked about when the market doesn't work? The market does not work in healthcare. But we like the market to work because it makes these hard decisions about allocating resources. It leaves it to the consumer. If I want to buy an old crummy car, I do that. If I can afford to buy a new car, I do that. We don't like to say that for healthcare, but then making those decisions is really hard. And how do we set up well-resourced, durable structures and processes? I'll get to this in a moment. The Green Mountain Care Board is one of the most advanced, and you may not like hearing this, it's one of the most ambitious, sophisticated ways for doing this work. I'm going to call you Elliot because I'm so tired.
Please.
Dr. Fisher is 4 syllables. Elliot is 3.
Can I just say, we agree with you?
Yeah.
Yeah, okay.
And think about Elliot's loop. This is just a chance to learn how to do it better. This is a chance for a process improvement around how do we do this oversight. So now specifically the policies to address rising commercial prices for hospitals. We actually just published work on this. The citation is there. I'll make sure that Kiki has it, specifically for an audience such as legislators going, okay, you got rising commercial prices. What can you do? These, I would actually think for you folks are baby steps. You've already done this. You're ready for, I don't know, at least junior high, maybe high school in terms of our educational thing. But what I was asked to spend a little bit of time on are these 3. How do you do something around reference-based pricing? How do you think about a hospital price growth cap? And then how do you review hospital revenue and/or price growth? And that leads to this discussion around global budget. So I'm going to spend a little bit of time on these last 3 items and then try to think about how they fit into an overall structure that you folks have in place. And this is assuming, again, we prioritize the issue of rising commercial hospital prices. If we're working on something else, we need some other strategies. Drug pricing, really important. A different set of strategies, different set of policies, probably with some federal cooperation. For instance, rural hospitals, important consideration as you think about the problem that we're focusing on. So reference-based pricing, it is a hot item. A lot of folks are talking about it. Let's make sure we understand what it says. You're indexing hospital prices to percentage of Medicare. You've seen this data. Oh my gosh, 350% of Medicare, that's outrageous. Let's pick a number, 250, 175, whatever number you pick. We have experience in other states. There are some items on your policy menu. You can apply it to a narrow set of services or more comprehensive. You can exclude certain hospital types, or you can apply it to specific market segments. I'm going to give some examples. The pros are that this gets you aligned with Medicare pretty quickly. You don't have to do a whole lot of work around cost analysis or anything like that. And it's a way to address what Elliot notified or called up the hospital consolidation issue. The cons are that you could be squeezing the balloon and a health system could just say, okay, well, we're going to make it up with utilization, or we're going to charge prices for the services that aren't affected. And we're not addressing the rebalancing issue. That's our real, I ask you to keep that in mind. Fundamentally, we have an out of balance health system. How do we build our community capacity if we want more prevention, more emphasis on social services? So what's been the experience? I just want to call up a couple other states. Montana was actually an early pioneer on this, led by the executive branch, and they did their state employee health plan. And they just told their administrator, because they're self-insured, look, you're only going to pay 20% 220 to 225% of Medicare rates. So it wasn't a big haircut and a different rate for outpatient services. I could only find data up to 2019. It generated a lot of savings. They just they said to the taxpayer, look, you're going to do this with the hospitals. They didn't even wait for legislative action. In Oregon, there was a law that was passed. Again, it was focused on public employees. They set it at 200% of Medicare for in-network and 185 for, actually, they did it out of network as opposed to inpatient and outpatient. That was to get the hospitals to stay in the network. Why did they pick 200 as opposed to 230? It probably was where they started. They excluded rural and critical access hospitals to sort of take them off the hook. They think that they have a study out of Brown thinks that they have saved 4% of total planned spending. Not the silver bullet, but significant. 4% is significant. That's a 4% reduction. That's not a reduction in trend. And they couldn't find any. The hospitals just ate it. Looks like they got the cut right enough so that hospitals just took the loss. They lost in revenue. They didn't try to make up for it someplace else. It's worth noting that Oregon and Washington are now considering applying this to all commercial health insurance. As you can imagine, hospitals in Oregon and Washington are not saying, oh, thank you very much. We will voluntarily take that reduction in revenue. This is my expense is your revenue, and you can look for signs of blood from your legislative colleagues as they negotiate this out. I do want to say one thing about, sorry, I'm going to go back to this from one other comment about reference base. Well, I said it in the pros and cons. This is a mechanism. It is in effect a tool or a strategy that's part of a larger plan. I think this gets to what Senator Lyons is worth you thinking about. What's the directive that you give, in your case, the Green Mountain Care Board? Do you say, go do this? Do you say, consider it and let us know what you're thinking about? It's worth thinking about what is if you want to investigate this, pursue this, what's your role and what's the Care Board's role? Similar a second strategy, hospital price growth caps. This is a little bit lighter touch. This is saying to hospitals, okay, we're not going to take money from you, but we're going to limit how fast you can grow going forward. This is near and dear to me because we did this in Rhode Island. We did this through health insurance regulation. In Rhode Island, we did not have hospital budget review. We documented this sort of payment disparity and price increases over time. The health plans were coming to us with rates. They were big rates, 5, 10%, 12%. We said, what's driving it? They said, our hospital prices. We said, why can't you do anything with it? They said, my hospital, I gotta keep the hospital in the network. I can't say no to them. Because they dictate the price. They have the market power. So we said to health plans, as a condition of your rates, you can only give CPI +1 to the rate, to your hospitals in your rate negotiations. The health plan said, can we do that? We said, let's find out. And it stopped. So we in Rhode Island, they've been doing this since 2010. In that time, Rhode Island has had the second largest, actually this fits well, the second largest, slowest growth in commercial premiums in the last 20 years of any state in the country. The number one state is Utah, where Intermountain is. So, and hospitals in Rhode Island have stayed in business. In effect, we've put them on a diet. You know, we've limited the rate at which their commercial revenues can grow. The advantage of something like this is that it's really easy to implement, relatively easy to implement and administer. And it's politically easier than taking away, because we weren't taking money out of the hospitals. We were just limiting how fast they could grow going forward. The cons are that to the extent hospitals are paid differentially, we were health insurance regulators. We didn't have the statutory authority to do that. It doesn't build community capacity, although we did some things around trying to rebalance and put more money into primary care. It doesn't really align with Medicare as much as people would like. And you've got this big self-insured business, although we think that the self-insured beneficiaries in Rhode Island have benefited from these price increases because it's the same administrators Blue Cross and United and Tufts, and they just turned to the hospitals and said, you gotta take it off. I'm waiting for my thank you note from Jeff Bezos and Walmart for lowering his premiums, but it hasn't come yet. The last piece,
You got a question?
yes,
I'm wondering, has it had an impact, however, on accessibility, limited services?
so we have a number, in Rhode Island, a number of financially weak hospitals. It's unclear how weak they are. In part because we don't have, I'm gonna speak as a Rhode Islander here. We don't have the insight into hospital finances that you folks do. So hospitals come and actually that we don't have for insurers. So, if you ask hospitals, they would say, yeah, I'm starving. And we do have some hospitals that appear to be fragile that are talking to owners, outside owners that we would rather not. But we want to, frankly, in Rhode Island, they want to force that question. I think the next step in Rhode Island is actually financial oversight, like Elliot was talking about this, a single source of truth around hospital finances, the way we have it for insurers. We have pretty good insight into insurer expenses. We don't into hospitals. And so when hospitals come and scream bankruptcy, we have to take their word for it because the state has not funded an adequate examination oversight structure to render an independent opinion around those sorts of questions.
What about quality in Rhode Island?
Well, from an outcome standpoint, we are Commonwealth Fund ranks overall high-performing health systems on a balance of quality, costs, health status. We are neck and neck with Vermont right now. But New England states always do very well. And so although the insurance regulators don't have responsibility for it, the hospital quality statistics have not suffered as a result of these.
Not suffered.
The last piece I was asked to talk about was hospital global budgets. The idea here in broad concept, and I'm at a very high level, is to set total or per capita budget for hospital services with adjustments for shifts, populations, and risk mix. Okay.
So that would happen at the Green Mountain Care Board level?
Yes.
Yes, so they would get that engaged within the services available. And then I'm going to ask you another question, which you're probably going to say, save it for later. I'll do that. But so within that mix, a payment mix, there may be fee for service, value-based payments, capitation, block grants, yes or no, or is that something to look at?
That's almost a flow of funds question.
Yes.
And I got bad news for you that when other states talk, they want to know what's going on in Vermont. And so you're sort of being looked at as pioneers around this. Mostly because of the Green Mountain Care Board. I will say what they do in Maryland is they set a budget prospectively on a per capita basis. I believe, and folks at Green Mountain Care Board can correct me, claims are paid on a fee for service basis, and then they reconcile at the end of the year. So the money flows, the hospital knows what they're going to get, they still got a bill, and then they reconcile at the end. It's not like there's a fork full of money handed over at the start of the year, like we do in some other budgeting models. It's important to note that Maryland's the most mature. They have had aligned payer rates between Medicare, Medicaid, and commercial for going on 40 years now because of agreement with Medicare. And they are proceeding on that. What they are doing could be construed as global budgets. You have to define what are the services that are in there. Again, to Elliot's sort of process improvement, they're continuing to iterate from a policy standpoint. The important things I would note are the next stage is their ahead model. So Maryland, like Vermont, is a first generation ahead model. There have been some changes in the federal administration. I was just talking to the folks in Maryland last week. They are proceeding full speed ahead with their ahead model. And so they're acting, we know it's uncertain environment. How do you think about something like that? And I don't, my observation, and I'm not, I don't meet with the folks at the Green Mountain Care Board, is that this for the Green Mountain Care Board would be a change in mechanism. They are already reviewing hospital budgets. And so it would, I don't want to say it would be easy, but it's conceivable to say, okay, instead of budgeting on the way we do for school systems, what are your past expenses? We're going to do it on a per capita basis. We're going to say, what are you doing on a per head basis? So I view the idea of global budgets as a technical implementation challenge, not a conceptual challenge, because you've already said, hospitals, we're going to oversee, health systems, we're going to oversee your budget. You've already created that accountability. This is a different way to do it. And not many other states in the country could say that. You're much closer to being able to implement this than other states because of the Green Mountain Care Board. It's worth from a definitional standpoint because we all have a lot of scar tissue around accountable care organizations, whether you're an advocate for it or an implementer as you are. The focus of hospital global budgets is on existing institutions, a health system, a hospital, whoever you decide. Accountable care organizations are trying to create new organizations. That was the ambition with OneCare. It's the ambition with the Medicare ACO program. So you're in global budgets, you're dealing with existing institutions. I frankly think that gives you a big advantage in terms of implementing because you're not trying to create new stuff, new relationships.
So our accountable care organization obviously is going to be defunct within the next year, this year. And however, there are some attributes that come from that in terms of quality, metric, data collection and analysis that might be helpful to the board in the work that they're. Well, that's a question.
I'll get you this. I have a national expert next to me, but that won't stop me from trying an answer first, and then you can correct me. The most important thing in what you're saying, I think, is this notion of accountability for the person, the population, to say, are you taking care of the needs of the person? And if you build a global budget on a per capita basis, you are still able to have that accountability. You're able to hold the hospital accountable for quality health as well as costs for the set of services that you defined. Before I go to you, is that anything to add?
Yeah, I think it's a little trickier for hospitals that don't have primary care systems.
Yes.
And so it is for the people who they are seeing, who come through the doors that they're accountable for under the hospital side.
Right.
You mentioned global budgets. You talked about the existing setup that we have in terms of the hospitals.
Yes.
I'd like to hear a little bit about how you feel about systemic change in the service delivery part of the hospital. You mentioned a little bit about it, having clinics strategically located, keep them out of the ER, because that's one of the most costly parts of hospital healthcare. So how do you feel about that? Because, I'm looking at this ahead program and I'm looking 3-4 years out. To me, there's a crisis now. At least 4 hospitals are ready to go under. So why not do that systemic change rather than do a global budget on the existing structure that we have now? Change the structure of service delivery. Do it now instead of waiting.
Yes, and I actually think that's possible within, as I understand it, within the AHEAD model. The AHEAD model has the ability to, one, develops that community capacity, primary care, the support services, and I'm going to speak about that in a moment. And then in the process of the budget setting, you're setting the budget for these different hospitals. So to the extent you have concern, not just about one big health system, but other ones, that's all in how the money is allocated. It is, and whether the planning process can dictate, I guess is what I'd say, the planning process can dictate the priorities. So there certainly is the capacity to articulate the priorities that you're talking about, which, by the way, I support. I think to address the long-term issues that Elliot's talking about, you need stronger primary care in your communities.
I'll just make one technical distinction between the two systems. The hospital budgets are responsible for about half the costs. Oh, thank you. Hospitals are responsible for about half of the spending. You still have primary care, other community-based services, the physicians who are employed by the hospitals. And so one of the other distinctions is that under the ACO model or whatever the redesigned system, because I agree with your aspiration to create a better system, is do you want people accountable just for the facility-based spending? Or do you want people to take responsibility for improving the health and care of all of their patients?
That's part of it is the prevention part of it.
Yes.
Yes.
Yes, absolutely.
So if you want better care for everybody, this model, which has for an aligned primary care population, people who are, and there are ACOs that are doing very well. They're very effective. They're just not implemented broadly. Let's come back to that because I want Chris to make sure he finishes.
I think hopefully my comments get to some of that.
So there's one more question over here.
I'm sorry.
I do have a question to talk about after all of this, and that is regarding our blueprint model and the work we're doing on 167 and ACOs together. But
I got that.
I'm going to hold that thought.
So solid.
I got it.
So are these,
Representative Houghton.
thank you, are these either or models, right? So do you do all, do you do one? And is there any data, and I think this has been asked a couple different ways, is there any data for each of them about access and quality? So everyone always talks about the savings, but access and quality is a real issue in our state. And to Representative McFaughn's point, what is going to get us out of our crisis?
I'm gonna go back with a question. How do you define the crisis?
The crisis is we have low access, quality is so-so, and really high costs.
Okay. So, and that's part of what I said at the beginning, you're broadening the challenge because you're putting access and quality in as well as the price.
Yeah.
But you're the policymaker, so that's your prerogative.
That is my prerogative.
You define the problem. To your first question, I would think about these as developmental stages. Global budgets is a more complicated and more sophisticated approach to the same set of issues. I think it offers more potential. But what I really want to emphasize is you've got the tools in Vermont to do this because of the capacity you granted the Green Mountain Care Board. These other states, Oregon, Washington, Montana, that are looking at reference-based pricing, they don't have combined insurance, health system oversight, insight into financials. So it frankly would be a distraction to stop at reference-based pricing. When you build a global budget, you're going to be incorporating some multiple of Medicare into it. So, aggressive for advice, this is the sort of, you're already there, frankly. You need to give some more direction. In terms of long-term outcomes to get a quality access, what the things that Elliot pointed to, it has to be built into this. You can't just say, well, reference-based pricing is just an incremental step where I want to do reference-based pricing to save some money, and I hope it doesn't hurt my quality or my access.
You hope.
You hope. And so far, the data is that it doesn't. But it's it is, Vermont has always been marked by the size of its health policy aspirations. And you've got this chassis with the Green Mountain Care Board. You want to build off of that.
Thank you.
We have another question.
Feel free to punt this for later broader discussion, but it's related to the access issue, and that might be putting me on the spot a little bit. You were earlier talking about economically rational behavior, and I'm speaking specifically about the Green Mountain Care Board asking hospitals to reduce the cost of their services. And my hospital taking that edict and focusing on net patient revenue and reducing net patient revenue, which is having the impact of closing badly needed primary care clinics, badly needed outpatient dialysis clinics, lowering and I'm experiencing this as a frontline worker, and others, clinicians that I've talked with are experiencing a forced reduction in census. Again, I think getting at lowering patient revenue and reducing reducing census when there's actual need and patients waiting to get in for care. It's not that there aren't people out there that need access. So access is still the issue that the hospital is cutting.
If you will, cutting in the wrong places.
But this is an important question, and I think we probably should come back to it after your presentation and after our break, because it is one of the emergency pieces that's driving more change. Yes, and it's being played out in the media again, and it's something that's happened at the board level with budget decisions, not overall planning, not ongoing consideration for strategic planning and global budget, but there are decisions that are made within the budget process that then result in loss of services and patient access. So, so I'm thinking that this is one of the things that brings us right here, right now. So,
I'll give what's going to be a really unsatisfying answer. What I would do if I were you is actually call colleagues in Maryland, and we can help you with that, because Maryland, if you think developmentally, Maryland's further down this path than you are, where they're trying to set and limit hospital revenues. That's really what our health system, let's call it health system revenues. And what happens when that results in desired cuts in service, less desirable access? How does a Maryland setup respond to that and prevent that from happening? And I think it's a really important question. I'm sorry I don't have more than you just have to monitor access answer. And I think the place to learn is from Maryland. And also to learn what's the role of the legislature in that and what's the role of Maryland's oversight. Because Maryland has in place commissions to do this work. So
The Green Mountain Care Board.
And the equivalent, and I'll talk about that, is the Green Mountain Care Board.
you got more?
Yes, I'm sorry. Okay. A little bit more about global budget. It is more advanced. So you get direct alignment with Medicare and self-insured. It moves the hospitals from fee-for-service and makes rebalancing conceivable. So Maryland tells great stories. Once they were on a global budget, they stopped advertising their emergency room. They stopped advertising their radiology services. They started supporting children's obesity prevention in schools in their community, because they were still getting the same amount of money. They just didn't need it to come into their ER or their radiology. So it makes that sort of rebalancing really possible. It doesn't necessarily make it possible to build more aging services, stronger primary care. It depends, again, on what you put in the budget and hold them accountable for it. It also, by the way, is a guaranteed future for the hospital. You fight over the amount of money, but at least when I'm running the hospital, I know I'm going to get something. The cons, you could argue that what Green Mountain Care Board is doing is, well, they're certainly doing budgeting. What does it mean to change it to a global budget? Maybe it means moving it to a per capita basis. It's a really significant analytical lift. As I said, it doesn't build the capacity of community services. You have to tell Medicaid that they're part of the process so they can go off on their own. That's been some issue in Medicaid. It's really hard to maintain political will because the first time the regulatory entity says no, they're going to come to you folks and say, fix it. Give me more. There is, look at what's playing out in the Green Mountain Care Board. My costs are my costs. I can't take anything out of that. And if you make me take costs, I'm going to kill the baby. Okay, we've seen that plan. You want me to take costs? Do you really? I mean, I've been a
We
policy.
just heard about that.
I've been an executive branch person. I get orders for budget reductions from you, and I deliver the worst possible scenarios. I know how to play that game. So how do you? These problems are inherent in any kind of public budgeting process. So back to our barriers, and I just got a couple more slides, a few more. How do you align policies between payers? AHEAD goes all the way there. Reference pricing is pretty easy because it goes with Medicare. Growth caps are even lighter. This gets to your question. How do we do reasonable, durable structures and processes for planning when the market doesn't work? You guys are in the position to learn from your efforts to do this with the Blueprint for Health and Green Mountain Healthcare Board. Green Mountain Care Board. You have much more learning, much more experience than most other states. So they are going to be coming to you, frankly, to learn from this. And what I would say is, I want to go back to the Blueprint for Health. Senator Lyons asked about this. I've been a longtime supporter of this because it is an explicit effort to strengthen our primary care capacity. And Vermont has a running start on this. You've got the Blueprint for Health. You have a very strong footprint of community health centers that are, frankly, you've got more community health center utilization than other places. And you've got the blueprint, and that blueprint model was really essential for you folks with opioid and COVID and now aging services. You do it for SASH. It was eclipsed by OneCare. The bet was that if we could create this accountable entity, they would invest in primary care by themselves and would build up primary care because it would be in their interest. If it's any consolation, the fact that it didn't happen in OneCare is the same thing in Medicare. What they found was that hospital-based accountable care organizations didn't reallocate. They just kind of played along with the game until Medicare gets tired and lets it go. But when you really have primary care organizations accountable for the whole thing, and I'm not saying tomorrow we should put all your health centers at risk for everything. It actually works. So I don't see global budget and strengthening primary care as either or. I don't even see accountable care in global budgets or. You just want to move slowly with your primary care and build them up over time. I would say my observation, there are people who are closer, over time, the Vermont Blueprint for Health has lost its ability to put in significant additional money to set that policy and planning agenda. So it's become lower profile and has had, I'm not even talking about what its budget is in terms of allocation, but it has less authority to do that kind of planning function. So
Do you have a suggestion? Maybe that's something we could pick up. It's a question that I have for you afterwards, so I can hold that thought about.
yeah, well, and I think I would think about your questions about blueprint. This is Elliot's slide.
Yeah.
Back to a learning health system. This is not only a learning health system for UVM or any other health service in itself. It's a learning system for Vermont. What have we done? What can we learn to do? And I think that evaluation and planning function is where you say, in this case, we want to strengthen primary care. We want to strengthen our community capacity. We want to put resources in there. And so where the last piece that I got, or the next last piece, is just, and I apologize, this is sort of big thinking. Why is this there? It's loading. When the market, this is myself. If we can't rely on the market to allocate, who does this work of allocating? How do we do this in other places with public goods? And I looked at education and public utilities. This is very, very high level. It's worth oversimplification, public utilities, we give it all to one thing and we let them do it and deal with the regulated entity. That would be like creating an Uber strengthening the authority of the Green Mountain Care Board. And you would hold them accountable for certain things. In education, we've got the agreements. And so the state is raising money and sending it to the locals. They're setting some standards. We have no locals for healthcare. We got a bunch of health centers, we got a bunch of hospitals, so you have no kind of locally controlled entity that you can give to. On the rightmost in Maryland, I think that's a place you can learn from. Their evaluation and planning rests with the Maryland Healthcare Commission. It's not dispersed across a bunch of different agencies. So the Maryland Healthcare Commission says, we want to go big into primary care, or we want to go big into community services. They set that kind of priority. Here, as I understand it, it's dispersed across a bunch of agencies. So you have some planning happening in the Green Mountain Care Board, some happening in Medicaid, Department of Health Access, the legislature. The implementation for providers is spread across everybody here because that's your Green Mountain Care Board is determining budgets, but DOH has some funding authority. Medicaid pays directly. Public employees is making their own decisions. Medicare, Maryland, it's still complicated, but there are a bit fewer. It's trying to get fewer moving parts. And then in terms of who interacts with the payers, it's the Green Mountain Care Board in Vermont, Connect, your exchange. That's a lot better than some other places where they don't have that centralized authority. Maryland, they have their insurance regulators. And then you have this measurement and monitoring, what's going on real time. So this is a lot. I just think it's something. It's really important for policymakers to think about this as well as what's the right payment method, or do we want to advance primary care? How do we do this work? How do we have this kind of learning health system that Elliot was talking about? I'm just going to race through this and again, the conversation. I'm circled this just to point to the complexity. I think that's your point of comparison, and there's a lot to learn from Maryland. And your challenges are defining your priority problem. Is it affordability or is it accessibility and quality? And the problem of cost reduction is hard. You got to say no to people. How do you do that? Or can you how do you strengthen the Green Mountain Care Board's ability to do that? And then how do we learn from your grand experiment with the Green Mountain Care Board, which I encourage you to think about it in a learning way as opposed to a failure. We've been doing it. We're learning some stuff. Let's make some improvements. Don't, I guess, throw the baby out with the bathwater. I think you need alignment with Medicare. My own opinion is that a head is too good to pass up if you know what you want. But you need resources for that health system and planning function. Whether you have to decide as the legislature, is that in Green Mountain Care Board or is it someplace else? I think you need an explicit strategy as part of that planning for health system rebalancing. And to Senator Lyons' question, you got to think about how you how you bring them here. What is it that you hold them for? I don't think, my own opinion, you say go do reference-based pricing. But you do say, what are you, on a regular basis, what are you doing, why, and what are your results? So that that's the accountability. And you've got the power of the purse. Last thing, this is just me personally. I'm a big Vermont fan. I'm a Vermont boy. Whether in Mount Mansfield, Lake Champlain, or
Familiar.
Upper Valley, if I could convince my wife to move up here, but we're big fans of what you're doing.
We need more taxpayers.
Yeah, you need more taxpayers, right?
You're welcome to join us.
So keep up the good work, and both for myself and for Millbank, we look forward to helping you with this going forward.
Well, thank you for that. And I've got questions, and I think others have questions. But I think it would be helpful for us to take a break. And then we're going to come back, and I'm going to invite Green Mountain Care Board and the folks from Brendan and David, and I see that Owen Foster has come in and Jessica Holmes. We all want to come up together and we can have a conversation around the table, asking questions. That's one of the things that I like to do in my committee, and I think it's really healthy to do that. I have some difficult questions to ask, not difficult for you to answer, probably as much as difficult for some of the folks in the room and how the problem is playing out. So let's take a break.